Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we review and provide commentary on resources, literature, and we discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development. For more information about us and continuing education, go to our website, www.slpnerdcast.com. You can find permanent products, notes, and handouts. Some items are free, others are not, but everything is always affordable. You can visit our website to submit a call for papers, to come on the show and present with us. Contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and fair representation of each topic that we tackle. That being said, it is always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We love to hear from you.
So real quick, before we introduce our incredible guest for this episode, one quick housekeeping thing. We are releasing this episode in February of 2021, which we have deemed Funding February. We usually mention in our intro that SLP Nerdcast is brought to you in part by listeners like you. We are nowhere near as cool as NPR, but the same concept applies. Individual support from our listeners keeps SLP Nerdcast going. It keeps our prices low for CEUs and keeps the podcast ad-free. If you are able, please consider going to our website or social media pages and contributing. If each one of our listeners contribute $1 or $2, we would be able to cover our costs for a whole year, which would keep access to our episodes free, keep our episodes ad-free, and keep the prices for ASHA CEUs as low as a very fancy cup of coffee, but a cup of coffee nonetheless. We wouldn't be here without your support, and we're so grateful to have all of our listeners on this nerdcasting, podcasting journey with us. Yes. So without further ado, today we have the great pleasure of welcoming Dr. Lindsay Griffin. Welcome, Lindsay.
Hello. Thank you for having me.
Thank you so much for joining us.
Lindsay, you are here to discuss dysphagia with us today. And before we get started, can you please tell us a little bit about yourself?
Sure. So I'm an SLP, and I worked in, I guess, across the continuum of care in acute care and rehab and outpatient since I got my master's in 2012. And then in 2016, I made the bold decision to go where no SLP has gone before. Well, few SLPs. And I got a PhD. And so now I am an assistant professor at Emerson College in Boston. And my specialty is dysphagia or swallowing disorders.
I said it wrong already. I'm starting. She says dysphagia. I said dysphagia. Messing it up already.
So all of our listeners know that Amy and I don't know anything about this at all. And we are really excited to have you teach us all of these things. That's the whole reason why we love this podcasting adventure, because we get to have these really wonderful conversations with professors like you, smart PhD people like you. So I think before we get started and before we read our learning objectives, let's get the record straight. Dysphagia.
Tomato.
Okay.
All right.
Although there are people who live and die by one or the other. So know your audience. But I think I do say dysphagia, though my wonderful professor in my master's department did say dysphagia. So
what you're saying is we can all get along.
We really can.
Okay, great. That's perfect. So all of our audience, all of our listeners who are listening, who have a strong opinion, please forgive us. We will try to use the terms interchangeably throughout the course of the episode.
To appease all people.
Yes. This is an inclusive episode here. All right. So let's go over our learning objectives. Learning objective number 1, describe the difference between restorative exercises and compensatory strategies. Learning objective number 2, relate 3 restorative treatment techniques to the targeted physiological impairment. Learning objective number 3, identify 2 devices used in dysphagia rehabilitation. So I already have lots of questions because I don't understand any of those lots of that terminology. Before we jump in and pass the mic to you, I need to read all of our financial and non-financial disclosures. So listeners, we know this is dry and boring. Stick with us. Lindsay Griffin financial disclosures. Lindsay is an employee of Emerson College. Her non-financial disclosures. Lindsay is a member of ASHA SIG 13 and the Dysphagia Research Society. Kate, that's me. Financial disclosures. I'm the owner and founder of Grand Bois Therapy and Consulting and co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA SIG 12 and serve on the AAC advisory group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group.
Amy Wago, that's me. I am an employee of a public school system and co-founder of SLP Nerdcast. And my non-financial disclosures are that I am also a member of ASHA SIG 12, and I serve on the AAC advisory group for Mass Advocates for Children. All right, Lindsay, tell us everything. Make us smarter.
Okay, so let us start with some very swallowing basics, and let's talk about the normal swallow. So when we swallow, we have 3 to 4 phases of the swallow. And the reason I say 3 to 4 is because the first one is oral prep phase and the second is the oral phase. Some people lump those two together. And so then if they lump them together, then they would say there's 3 phases. If they separate them, they would say there's 4. I personally like to refer to it as 4. So in the oral prep phase, then the oral phase, the pharyngeal phase, and the esophageal phase being the 4 phases. And so the oral prep phase is all of the things that you have to do to get the food or the drink ready to swallow. And so like if you take a sip of water, your tongue sort of naturally cups it and forms this bolus, and then you swallow it. Similarly, if you like chew up a graham cracker, you use your teeth and all of your tongue and your cheeks and the lips and all of these things to munch and munch and munch until it also forms sort of this like little ball, which we call a bolus. So all of the things that you're doing to get the food and the drink ready are part of the oral prep or oral preparatory phase. The second that it is ready to swallow and you are trying to send it from the front of your mouth to the back of your mouth, that is the oral phase. And so the oral prep phase is under volitional control. You can chew as long as you want to, but the oral phase is less so under volitional control. And so when you begin to swallow, it kind of, your body overtakes it and it starts. The oral prep phase could be super, super long because you have that control over it, but the oral phase itself is super short, like 1-ish second, maybe even less than that. And so once the oral phase is complete and the bolus is leaving the oral cavity and entering the pharynx or the throat, that's when the pharyngeal phase starts. And I'm biased. I love the pharyngeal phase. I think that's where the magic happens. And
Are you not supposed to have a favorite phase?
I mean, really, they're all important. If you didn't have an oral phase, you couldn't have a pharyngeal phase necessarily. But the pharyngeal phase just has my heart.
So why? I got to know.
Because that's where all the good stuff happens.
Like what?
That's when a whole bunch of things, a patterned response occurs. So the hyoid bone, like the Adam's apple in the throat, that comes up towards your brain and out towards your computer or whatever's in front of you. And that movement helps to pull the larynx up and helps with airway closure. And so the true vocal folds close, the false vocal folds close, the epiglottis, which is that piece of cartilage in our throats, bends down and covers the airway, and the arytenoids, which is kind of in the posterior part, they bend down and cover. So there's 3 to 4 levels of airway protection, and part of how you achieve that is through the hyolaryngeal elevation and excursion. Simultaneously, your pharynx is contracting, and so the back of the tongue comes backwards and meets the back of the wall of the throat. As the back of the wall of the throat, the pharyngeal wall comes forward, and they form a pressure, which helps to push the food or the drink down. So you have airway closing, things being pushed through. And then also with the hyolaryngeal elevation and excursion, it pulls open the top of the esophagus, which is a muscle called the pharyngoesophageal segment, PES, frequently also called like the UES, upper esophageal sphincter. And so that muscle is closed at rest. And then when we swallow, all of the muscle relaxes to let all the food or the drink enter. So now do you see why the magic
Yeah, no, that's awesome.
in the
Totally.
pharynx?
I see it. Pharynx is the coolest kid
Pharynx
at the
is
party.
king.
It really is.
I learned like 3 things there from my 15-year-old dysphagia class from graduate school. I'm already smarter. Keep going.
No, yeah, this is great.
Okay. So then after everything the PES opens and everything goes through into the esophagus, then the esophagus drains in mainly 2 ways. One is gravity, pushes everything down. And then the other is that it has this natural movement that goes back and forth, and it's called the peristaltic wave.
I was going to say, I know the name of that. It's peristalsis.
Yes.
And then
nice.
throwing up is reverse peristalsis, right?
Yeah.
Little tidbit, listeners. Enjoy. That's all I have to contribute. I'm out.
So the first wave is the primary peristaltic wave, and it's the strongest. And then there's a secondary wave and a tertiary wave, etc. And so in 8 to 20 seconds after food or drink enters the esophagus, it should be through the bottom and into the stomach.
I have a question.
Yeah.
Is swallowing in the esophageal phase within the scope of practice of the speech pathologist, or is that usually something that is done in conjunction with another professional?
Gastroenterology or something.
It's a turf war.
Oh, interesting. Okay.
We enjoy a discussion of a turf war.
Yes. So depending upon where some people work, the radiologist will not want to like scan the esophagus during the modified barium swallow because they don't feel like it's within our scope of practice. But what did I say at the very beginning? How many phases of the swallow are there? What's the last one? Do we do swallowing? Yes, we do.
Interesting.
So, and then also like the upper esophagus where the PES is, that is within our scope of practice because it is still within like the pharynx. And so if we're like looking at the upper esophagus, why wouldn't we look at the lower esophagus? And that is not to say that we necessarily treat the esophagus. So like if somebody has a pathology, we would refer them to GI. But I personally feel strongly that it is within our scope of practice to at least screen the esophagus and then provide direction at least to the patient. Like, you know what? Nothing's stuck in your esophagus. Doesn't seem to be an esophageal issue. No need to follow up with GI versus like, yeah, you know what? It looks like there is something going on there. Why don't you follow up with GI?
Interesting. Okay. Good to know.
Yes. So then at the bottom of the esophagus is the lower esophageal sphincter, which similarly to the upper esophagus relaxes, let the food or drink enter the stomach, and then the swallow is over.
Okay. So we've got a good understanding of the swallow, soup to nuts, from a mechanical, physiological, anatomical functional perspective. So when one of those phases is not working and you have a suspected swallowing disorder, I'm just thinking about our first learning objective now that I have this picture in my mind of these graham crackers going through these 4 phases, or the wine that I'm going to drink later going through these 4 phases. And the concept of restorative exercises and compensatory strategies. So tell us a little bit about what that's all about.
Yeah, so some of the things that are going to be recommended to an individual with dysphagia could be a compensatory strategy, which is something that is done in the moment of the swallow to make that individual swallow better or safer, but is never going to fix the swallow. Versus restorative exercises are things that the patient is given in order to actually try to improve the swallow.
Okay. Like what?
Well,
do you have examples of those?
I do. I have lots. Okay. So a compensatory strategy that is frequently recommended is the chin tuck. And so as that sounds, the person brings their chin down to their chest and swallows while keeping their chin down. This can be recommended with solids or liquids, and it is a very commonly recommended strategy. But that's never going to fix the swallow. It's just going to make that individual swallow safer. However, this is a soapbox issue for me, and I would like to talk about the chin tuck for a hot minute.
I want to hear it. Soapbox granted.
Thank you. I cannot tell you the number of times that a patient comes to me and says, like, before, like an outpatient especially, or even an inpatient actually, like maybe they're inpatient and they told their nurse they were having trouble swallowing, and then the nurse said, tuck your chin and I'll consult speech. And then we get there and the patient says, I've been tucking my chin because the nurse told me to. Or the patient goes to see their PCP and also says, I'm having trouble swallowing. They're like, tuck your chin and go see speech. So a chin tuck can actually make the swallowing worse.
No,
it's true.
It's not magic.
It's not.
All right.
And so it drives me crazy when patients come saying, I've been tucking my chin because some other healthcare professional told me to do it. And so when we bring our chins down to our chest, it does a bunch of different things. But one of the things that it does is if you have residue or food or drink left over in the piriform sinuses, which are the bilateral pockets that are closer down, kind of like above the PES, well, on MBS they're above, but they're kind of next to it, or kind of like behind the airway. So if you have residue left over there and you bring your chin down to your chest, it actually increases the likelihood that that residue is going to fall into your airway. So don't like it.
And like one of the rules of swallowing, as somebody who doesn't remember a lot about swallowing, is we don't want the bolus to get into the airway. Right? That's a bad.
Aspiration is bad.
We certainly do want to try to avoid it when we can.
So obviously this is being prescribed by uninformed professionals as a blanket treatment. And I have to assume that with most things in speech pathology, the treatment recommendations are specific to the components of deficit.
Right.
So in what circumstances would a chin tuck be an appropriate strategy, compensatory strategy?
It can be helpful for some patients that have more of a delayed swallow. And so, historically speaking, we have said that when the head of the bolus, so the front of it, gets to about the angle of the ramus, that's when the swallow is triggered. And so what that means is that the sensation of that bolus being there, that the sensory information is being sent to the brain, and the brain is sending a motor message back that, hey, pharynx, time to do your job. And so it makes all those cool things happen. However, more recent research has indicated that the timing of when that motor message is, either when the sensory information is sent or when the motor message is received back, is variable among people. And so just because somebody doesn't trigger their swallow at the angle of the ramus doesn't necessarily mean that they have a delayed swallow if there's no like physiological impact related to it. And so again, like taking that one little part and putting it in a bigger context of the individual person is really important. So let's say somebody actually does have a delayed swallow, and so they aren't having proper airway closure, and the bolus is coming down too far and it is entering the airway, then a chin tuck can be helpful at trying to prevent that from happening. Another thing it can help with is if there's residue in the vallecula, which are also bilateral pockets, but they're higher up, kind of like behind the base of the tongue. And so a chin tuck can help because the chin tuck helps that base of tongue to push backwards and the epiglottis to deflect. And so then it kind of helps to really shove that food or drink down.
I have a question about restorative exercises, but before I ask that question, I'm wondering if there are other compensatory strategies that you want to walk us through quickly.
Sure. The head turn is also another one that is more frequently recommended. Clinically, I tend to recommend it most for patients with like a unilateral paralysis, like a vocal fold paralysis, Sometimes if there's like significant unilateral residue, so like if somebody had radiation treatment for head and neck cancer and has a lot of residue on one side versus another. And so with the head turn, the person is just turning their head to the side, so their chin is kind of like over their shoulder, right or left. And sometimes it's obvious which side you should recommend, but other times you kind of have to play around with it on a modified barium swallow and see which, if any, side is more effective for that person. But neither of those, the chin tuck or the head turn, will make the swallow improve. It will just make that single swallow safer.
So are there things you can do to make the swallow better?
There are. Those are those restorative exercises.
Restorative exercises.
So also one of the more commonly recommended is the Masako Maneuver. And so that one, the person sticks their tongue between their teeth and then they swallow while keeping their tongue between their teeth.
Is anyone else out there also doing this as she says it? I'm sitting here biting my tongue in between my teeth and trying to swallow. That's tricky.
It is tricky. And disclaimer, this is something that should never be done with food or drink in the oral cavity, just saliva.
Interesting.
It can increase the risk of aspiration if somebody were to do it with food or drink.
Is that a good general rule to apply to these like compensatory versus restorative, or no? Is that specific to the Masako?
That's more specific to the Masako. There's another one I'm going to talk about that it's not swallow specific. But most of the time, if you want to improve the swallow, you do want the person to be swallowing as long as they safely can swallow something, because that is what you're after. It's kind of like the, searching my grad school memory, the idea of like oral motor exexercises for kids don't help with articulation.
That was going to be my question.
Yeah. Great. Perfect.
Sounds like if you want to get better at swallowing, for the most part, practice actually swallowing.
It's true. Yeah.
All right.
So the Masako, no food or drink, tongue between your teeth. And so the idea with that is that if you recall when I was talking about the normal swallow, when we swallow, the back of the tongue comes back and meets the wall of the pharynx, and they create that pressure. So I tell patients to imagine that they have like a tube of toothpaste and they're holding it upside down and they're squeezing the bottom of the toothpaste and then it's coming out the top. Frankly, how all people should squeeze toothpaste. But I know there's difference of opinion. So anyway, that is kind of what happens when we swallow. The base of the tongue and the pharyngeal wall squeeze together and it pushes the bolus through. And so the Masako, by having your tongue further out and your tongue between your teeth, it has to work harder to reach the back of the pharyngeal wall, and the pharyngeal wall has to work harder to meet the back of the base of tongue. And so it's a resistance exercise. You are your own resistance. And you can have the patient put like just a little bit of their tongue out. It's not so difficult. You can have them put like all of their tongue out. It's more difficult because
oh my gosh, that's really hard.
Mm-hmm. Really?
I feel like taking it like for anybody who's listening and actively trying to stick your tongue far out of your mouth and then swallow, it's difficult.
It really is.
It really is.
You ask patients to do it repeatedly, a few reps of it. They run out of saliva. It's hard to begin with.
Interesting. So, okay.
Yeah.
What are some of the other restorative exercises in existence?
The Shakir, and or the CTAR, which is chin tuck against resistance. And so they're two actually different things, but they target the same physiology. The Shakir is, I'm going to say older. It's been around longer. And it's named after Dr. Shakir. It is spelled like shaker, but is not pronounced like that.
Okay.
And so in the Shakir, there's two sort of things that the person does. The first is, well, in both of them, the person lays flat on a bed or the floor maybe. And so the person lays flat and then they bring their just their head up and they look at their toes, but you keep your shoulders back flat on the bed or floor, whatever they're laying on. And so You do reps of that where it's like up, down, and then also you do a few reps where you hold it. So you look down at your toes and just hold and then relax. And so there's that. And then also the CTAR, chin tuck against resistance, sort of came from older folks or folks who have had neck surgery having a difficult time completing the shakir because it can hurt, and we don't want that. So the CTAR is the person sits in a chair and they have a ball that is the right size and the right amount of air in it, and they put it under their chin, and then they press their chin down against it. So it's a chin tuck against a ball. So it's a chin tuck against resistance. Both the shakir and the CTAR help to strengthen the muscles that are responsible for the hyolaryngeal elevation and excursion. And so then because those muscles are getting stronger, then you should expect to see improved airway closure as well as increased PES opening, so pharyngoesophageal segment opening.
So just to sort of recap and send this back to you to make sure I've understood it, there are these restorative exercises that are evidence-based, not the same as oral motor exercises for articulation. They are effective. I'm wondering how the effectiveness is measured. So I'm thinking about, experiences in PT where you go home and you do your home exercises X number of times per day. How do you measure progress based on the exercises that a patient has done? Like, do you ever see a patient like, you haven't been doing your exercises and I can tell because of blank? Obviously, still aspirating on food would be one indicator, but what are some of the other ways that you measure progress in that area?
For the most part, it is going to be like based on the I'm going to say milestones that the person is meeting. So like if they weren't able to swallow a certain consistency safely before, and so now they've been doing these exercises, and you know what the goal of the exercises is. So is it increased airway protection? Is it better bolus propulsion through the pharynx? Whatever you're sort of targeting. And then after they do those exercises, then you come back, you test them again, and oh look, their swallowing is better. So the exercise has helped. Sometimes it can be patient report measures, like the patient quality of life stuff. But usually it's going to be if their diet was able to be upgraded in any way, or if it's more comfortable to swallow now.
Interesting. So all of that measurement is done presumably during an MBS. You have them come back for a repeat assessment.
Yes, for the most part.
Interesting. Are dietary changes considered compensatory strategies also, or is that?
Yes,
Okay.
They are compensatory because they're also not going to make the swallow better. There's also a rating scale called the Modified Barium Swallow Impairment Profile, MBS-IMP. It was developed, I think, in 2007, if I'm remembering correctly, by Bonnie Martin Harris, and it aims to define different components of the swallow, so that clinicians are sort of rating modified barium swallows on this using the same language. And so that can be an outcome measure too, at noting if there's been improvement in the swallow, not just like the functional impact of the potential swallowing exercises, but also, like, oh, the hyoid was like a 2 and now it's a 1, meaning that it's better. Things like that could also be a measurement of improvement.
When you're prescribing these restorative exercises, is there a general timeline within which, like for us, working in AAC, there's a lot of variability between, like, I might recommend an intervention, but I'm analyzing the data on an ongoing basis and trying to make decisions about, is this effective? Do I need to change something? Is there a lot of variability similarly in dysphagia where you see, I've given you these exercises, maybe I need to change something because?
Yes. I mean, you can always change things midway if it's not going how you want it to, or if some person's doing better and then you want to move on to something else. I will say that one of the pitfalls of dysphagia research is that we really don't have very good understanding of the how often the person should be doing the exercises and how many like reps they should be doing. And so we tend to sort of try to base that on some PT literature. And so we'll say like, oh, do 3 reps of 10 each day. So like 30 reps of this exercise. But that's not necessarily accurate because large skeletal muscles are different than like the small muscles that are responsible for swallowing. It's just different makeup. Even the tongue itself has 2 different types of muscle fibers. So the oral tongue, the more anterior, has one type versus the posterior tongue. I mean, because the anterior tongue is mainly for speaking. Well, that's what we use it a lot for. Where the posterior tongue we use mainly for swallowing. And so exercising those in different ways is also a consideration.
Okay, so thinking quickly about all of these restorative exercises and how they're related to what's actually happening in the swallow. And this is, I think, sort of starting to touch on our second learning objective. I have to assume that the restorative exercises that you prescribe are related to a specific, just like we talked about earlier, everything in speech pathology is, treatment is specifically related to the measured deficits and areas of need. So I have to also assume that the restorative exercises are prescribed and matched specifically to some sort of physiological impairment.
This is true. And
so
so that's
obvious.
Also, no, that's really important to like note though, because if somebody has like poor pharyngeal squeeze, if like they're just having so much residue because the bolus isn't just being like squeezed down, the toothpaste isn't working. You don't want to give them an exercise that's going to help with airway protection if that's not what the problem is. And so having a really good understanding first of like the normal swallow, and then having a really good understanding of this person's specific swallowing impairments, and not just like, oh, they aspirate on nectar thick liquids, or, oh, they have a lot of residue with puree, but trying to figure out actually why they're having those issues. That's the skill of our profession. And like, that's why it's within our scope of practice. And so if you don't have that information, you need to find it before you start doing dysphagia treatment, because otherwise you're just like throwing darts in the dark. Is that an expression? I don't
It
know.
totally is.
I think it should be.
It is now.
Okay, great. Thank you. So like the Masako really helps to do that base of tongue pharyngeal wall squeeze. So it helps with the constriction of the bolus to the pharynx. There's another exercise called the Effortful Swallow. And so the Effortful Swallow is also like frequently prescribed, and actually it can be compensatory or restorative depending upon the intent of it.
Ooh.
Interesting.
So could be like more bang for your buck. And so as it sounds, the effortful swallow is you are telling a person to swallow with effort. So I tell people to imagine that they have like a golf ball stuck in their throat and they're trying to really like squeeze with all of the muscles to get it down. And so it can be compensatory if you're using it to just in that moment get the residue down, or the bolus. But if you are having them do it as an exercise in an effort to try to increase that squeeze, then that's when it becomes a restorative exercise. Other ones that we talked about are the Shakir, the Sitar. As I mentioned before, those really help with airway protection because they're helping to strengthen the muscles that are responsible for the hyolaryngeal elevation and excursion. They also help with the PES opening, so getting the bolus through into the esophagus. There's another one that we didn't talk about yet called the Mendelssohn Maneuver. And so
I've heard of that one.
it is so hard for me to do. I actually can't do it. In 10 years I've been trying to do it and I cannot. And so I can explain how to do it. You tell the person to swallow. And as you're swallowing, you can feel like your hyoid rising. At the height of the swallow, when the hyoid is at the top, you bear down and hold your hyoid in that upper position. I think you count 2 seconds and then you relax. And so, especially since you're targeting the hyoid, you are trying to improve hyolaryngeal elevation and excursion. And some patients I have talked to about this get it immediately and they can just run with it and do it. Other people like me can never get it. And some people can get it with just like a little bit of practice. So that one also helps with high laryngeal elevation excursion, which then in turn helps with airway protection and PES opening.
So I have a question.
Yes.
I have lots of questions because I don't know anything about this. I have to assume that a lot of, or some, I don't know if it's a lot, there are some people with dysphagia/dysphagia who are presenting with swallow impairments because of some sort of neurological deficit or injury. And how do you accommodate for those things? So for example, if they have weakness because of some sort of neurological impairment, are there other things to consider there when you're prescribing a compensatory, or when you're prescribing restorative exercises?
Yes. So one of the first things to consider, of course, is their cognition. And so like the Mendelssohn, for example, that's, at least for me, a difficult exercise to grasp. And so is somebody cognitively able to complete all of the steps that are related is one thing that you're going to consider. Another thought about some of like the neuro components is that we tend to call the swallow a reflex, but it's actually not a reflex. If you like a true reflex would be like when you go to the doctor and they like tap your knee and your knee goes out and you can't really do anything about it. But if the swallow was a true reflex like that, then there would be no point in trying to rehab it because we have zero control over that knee jerk reflex. And so instead of calling it a reflex, we call it a patterned response. And there is a part of the brainstem in the medulla that sort of controls more of those reflexive swallows, like the swallows that you're just going about your day, like kind of like near the breathing center. You don't have to think about breathing, you're just doing it. When you're just walking around swallowing your saliva, or when you're asleep swallowing your saliva, you're not really having any like cognition about that. But if right now I asked you to swallow your saliva, then there's a lot more cortical involvement than when you're just not thinking about it and swallowing. And so that like upregulation of the swallow is super important for us because it indicates that we actually can change the swallow, and it can help to make the swallowing therapy meaningful, knowing that there is that neuroplasticity. And so if somebody has a stroke, for example, and has dysphagia, well, if swallowing just a reflex, then like, sorry, you can't swallow anymore. But the idea that there is cortical involvement and that we can make changes is important. There was this article that I read that was by Inessa Humbert, and she talked about this example that I always think about because I just think it's so great. And I'm probably going to butcher it a little bit, but the idea is if you like pop a candy in your mouth and you expect it to be soft, and so you like bite down on it, but it's actually super hard. The next time that you put that candy in your mouth, you're going to bite down a little more gingerly because you aren't exactly sure what to expect. And so your brain is taking that sensory information, is receiving the sensory information and then changing the motor plan in response to that. And so that is sort of like what we want to do with swallowing therapy, is we want to like figure out where the issue is and then provide the correct treatment.
That makes so much sense. And I feel like similar to the point that you were making with the, we don't have great literature in our field at this point that tells us exactly the frequency and intensity of these restorative exercises that are maybe a best fit. We do have literature that shows that they can be effective for people, right?
Yes. Yes, we do. That but one of the really big problems with swallowing research, and I mean probably all research, but I feel like my bias is that it's just swallowing research, is that it's really hard to get a sample of people that present with the same kind of dysphagia, with the same physiology, with the same neurological impact, and then do something with them and then say, look at this great outcome. And so we have like, this person did this and this is what they found, and this person did this and this is what they found. But like, this sample was 20 people and this sample was 50 people, but we can't really put them together and say it was 70 people because are there age matched peers, and all of the research things make it difficult.
So is the bulk of dysphagia research case studies? No.
No, there
It's
are,
just
I mean,
it's just mixed participants.
yeah, it tends to be. And then also, I mean, not all of it, but a certain amount is like, oh, we have all of these MBSs. Let's just analyze them for these different components and see like what we saw when we evaluated them. But they're not necessarily all the same types of patients, which is sometimes fine and sometimes not.
Interesting. I have to assume that makes it really difficult as a researcher.
It is very difficult. Yes.
Interesting. Okay, so I'm just doing another recap here. There are all of these maneuvers, and I say maneuvers. There are a variety of different restorative treatments that are effective and evidence-based, that can improve the function of the swallow or improve the swallow. There are compensatory strategies that are used in the moment that don't improve the swallow. The restorative exercises are matched specifically to the physiological impairment. And there are all of these additional neurological things that you need to consider when you're prescribing a treatment. Am I doing okay so far?
Doing fantastic.
Okay, good. So what are some of the other, I'm just thinking ahead and thinking about our last learning objective. Is there, which is related to devices that are used in dysphagia rehabilitation. So what does that look like? I mean, I have no idea. I have no zero of them.
Yes. Okay. So one of the more recently used lingual presses is the exercise, and so you can do lingual presses, which is just like tongue presses.
I'm picturing like little barbells for your tongue, but it's probably not quite so cute as that.
Well, it's a kind of is, but
Okay.
not big barbell shaped. And so one of the more popular ones is called the IOP, which is Iowa Oral Pressure Instrument or something like that. And so that is sort of like a handheld device, maybe like 2 iPhones in size. And then it has a sort of like a cord that comes off of it, and attached to it is a little air-filled bulb. And you have the patient put that bulb in their oral cavity. And so it depends on which part of the tongue you are targeting. If it's more front, they put it like right behind their front teeth. And if it's the back of the tongue, then you have them put it back as far as they can without like being uncomfortable or feeling like they're going to gag or anything like that. And you have them push up against the air-filled bulb with their tongue. And so this is nice for lots of reasons. Here they are.
Okay.
Number one, it provides the patient with visual like biofeedback. And so they can see, and there's a little light, kind of like when you're at a carnival and you hit the thing with a mallet and the thing flies up and tells you how strong you are. Same idea with the IOP. On the side of it is this little lit bar. And so the harder you press, the higher the light goes.
I feel like that would be, biofeedback is extremely effective as
I would be into
a therapy measure.
Indeed.
Yeah.
So you find like the person where they're at, what their strength is. I use that. It's not their pressure really, but we sort of equate it.
Air quotes. There were air quotes going
there
on.
were air quotes. Thank you. And then you set the IOP for the person individually, and then you can have them push and try to reach the target, or you can have them push and hold, and try to increase in that way. So the IOP is nice because it does provide the biofeedback. In most clinics where I've worked, we've had a few. They are expensive. They're about a little less than $2,000 for each one. Give it to the patient, let them take it home. Usually they have to like promise you their firstborn in return, and then they can take it home and practice it and hopefully see improvements.
That was going to be my question. I mean, that seems like it would be a great tool to have in the clinic to measure baseline or to like repeat measure improvements.
Yes.
But it also seems like it would only be effective if the person had repeated opportunities to use it and really, strengthen that specific range or, movement that they were doing. So I have to assume that hopefully gets covered by some sort of DME benefit. So for anybody out there who doesn't know DME, I that rolls off my tongue as an AAC person. It stands for durable medical equipment. And it is usually a division of your insurance benefit that will allow you to gain access to durable
Yeah.
medical equipment in your homes.
Wheelchair. Yeah.
Wheelchairs, walkers, and these can be for purchase to own, or they can be rented temporarily if you have a temporary issue. So that's why I'm wondering
Is the IOP? Yeah.
if the
covered?
IOP would be covered by insurance.
As far as I know, it is not. Usually the clinics, all the clinics that I've worked at who have had them, the clinic has purchased them and then loans them to the patient to borrow, and then they bring back. But that would be lovely if patients could have their own. There's also like cheaper devices. The tonometer is another one that I'm familiar with, but I don't think it provides the same level of biofeedback as the IOP.
Interesting.
Yeah.
Okay. So there are these devices, DME, maybe not considered DME, like the IOP and what was the other one?
Tongometer.
Tongueometer.
Yes. They're both for lingual presses. And there's the idea also that you can have the patient like do lingual presses against like a spoon or a tongue depressor as well, if the goal is to try to strengthen the tongue, the lingual tongue. But of course they're not getting the biofeedback then. And so if you don't have access to an IOP or an potentially expensive device, then there are alternatives.
Interesting.
Are there other devices, or are those the main?
There is another device that I enjoy talking about. It is called Expiratory Muscle Strength Training, or EMST.
Okay.
And so it's not swallow specific, but the idea is it is a small handheld device, probably like the size of like an inhaler, but straight, not curved at the end. And the person blows into it, and there's a little resistive piece inside of it. And so you have the person blow until there's like resistance, and then you set it for that individual person, and they're single use. So again, all the clinics that I've worked in that have had them, the clinic purchases them, shows the patient how to use it, sends it home with the patient, and they'll bring it back to like readjust the settings. But when therapy is over, it's theirs forever. And so the EMST, there's some evidence to indicate that it maybe helps with some laryngeal vestibule closure, but also really the main name, as the name implies, expiratory muscle strength training. It is intended to help to strengthen the muscles that are responsible for exhaling. And so those same muscles would be helpful if you were wanting to cough. So for example, if you are aspirating and then you have a cough response, but you have a really weak, junky cough, EMST could potentially help to strengthen those muscles, and then your cough would be maybe more effective at clearing the aspirated material.
Interesting. I have a question. I feel like I'm saying that a lot because I don't know any of this. All of these devices and I think some of the compensatory strategies and restorative exercises that we've talked about, I'm just operating into the assumption that these are mostly used in the adult dysphagia community. Is that true, or is that a bad assumption on my part?
No, this is very true. Restorative exercises and device-based things aren't typically done with pediatrics. And like the chin tuck and head turn, not really either. With peds, you're going to have other types of compensatory strategies, like positioning or like nipple type, if that's a young child, or different cups, I guess, too, not just nipples. Utensils. There's going to be like other compensatory strategies for the pediatrics.
Interesting.
About what age does the crossover happen? Like if you're like a teenager and now you have dysphagia, secondary to a motor vehicle accident or something like that, would you kind of fall into this, like we would give you potentially these restorative exercises? And
yeah, that's a great question. I don't know about an age, but certainly when they're like cognitively intact enough to be able to like follow directions. Like my 3-year-old definitely could not do the Masako maneuver reliably. However, like, I don't know, a 10-year-old probably could, 12, 13, maybe like a super mature 10-year-old. I don't really know. When my son is 10, I'll let you know if I think he can do it.
So, I mean, as a clinician working in I mean, you've given us so much information about clinically applicable strategies, and I have to assume that it varies significantly by workplace. You've discussed outpatient settings, inpatient settings. Can you tell us a little bit about the different considerations you might have based on the limitations of your work environment?
Yes. So in like inpatient acute care, there isn't a ton of time spent on treatment of dysphagia. It's mainly a lot of evaluation and reevaluation. And that's because in acute care, the patient is acutely ill. Their status can fluctuate regularly, and and it's a short period of time that they're usually admitted. And so research indicates that that's not actually that great because, as we know, like the sooner that people start treatment for anything, the better their outcomes are for the most part. And so a lot of times swallowing rehab will wait until the person is at rehab and inpatient rehab. And so in inpatient rehab, that certainly swallowing is one thing that will likely be addressed. If it's an issue, it will be addressed in inpatient rehab. And so depending upon the type of inpatient rehab, you might have different access to the different types of devices, but um, hopefully, I mean, you'll know the compensatory or restorative techniques and can recommend those things. It's great if the person has had an MBS in acute care that you can at least base your recommendations off of, but we all know that it's difficult for some facilities to have access to instrumental exams, whether that's fees or MBS. And so sometimes SLPs, I think, have to sort of like shoot blindly because the last MBS was like 6 months ago by the time the person is getting to them. So trying to advocate for that person to get a new MBS would be great. And hopefully the last MBS, whoever completed it, wrote it in a way that gives you an indication of what the physiological impairment is. And so you can try to come up with some treatment strategies based on the physiological impairment that you read, even if it is outdated.
That sounds challenging.
It can be, yes.
That sounds
And
like a lot of hurdles.
Yeah.
I mean, if you're saying that a lot of SLPs are shooting in the dark because they don't have the most recent or more recent data from a measured study, that doesn't seem like best practice.
yeah, I feel like the further down the rehab channel that you go, the further away you'll get from the MBS. And so trying to get, like, if a person goes from like an MBS, I'm sorry, somebody goes from acute care to a skilled nursing facility, and then their skilled nursing facility stay ends up being more of like a long-term stay, and now they're there for like 6 months, and the SNFs don't usually have access to the modified barium swallow or fees, other than like having a mobile van come or sending the patient to the hospital. But that takes time to get all of those things. And so, like, as the person is trying to get better, now they need a new test, but you have to wait for it.
That's
So that
unfortunate.
can be difficult. Yeah.
I was going to say that seems really counterintuitive because the whole purpose of being in these rehab facilities is to get better and have your status change. So you
Yeah.
would think there would be a better way to take frequent measurement on progress and improvement in this area. Do you have recommendations for SLPs in that position in terms of bedside swallow things that they can do? Or look at me saying bedside swallow. I don't even know if that's a thing that adult dysphagia people do. But are there recommendations that you have?
Yeah. So again, hopefully the last MBS report was clear in terms of not just the physiology, but also like what the result was. And so what I mean by that is, like, if you get an MBS report that says this person was aspirating thin liquids and every time they aspirated, they coughed, and then they're on nectar thick liquids, or there's a new diet pyramid called the IDSI pyramid. And so that would those are called mildly thick liquids, but the mildly thick liquids are formerly known as nectar thick liquids.
Okay.
So let's say they're on a thickened
I'm going to ask
liquid.
you about that in a second.
Okay.
Put in your hat.
Okay. And so then, maybe your MBS report is 6 months old, but that always coughed when they had thin liquids and were aspirating on the last MBS. So then you can relatively feel confident trying thin liquids with them and seeing if there's a cough response or seeing if there's any sort of response that was there before. However, the problem becomes if they were silently aspirating on the modified barium swallow 6 months ago, it becomes really difficult to upgrade them sort of like at bedside or doing like a clinical swallowing evaluation with them because you don't have X-ray vision and you don't know if it's going well or not. So actually one of the biggest pieces of advice is that acute care therapists need to be writing their reports and everyone needs to, because you could get one in rehab as well. So everyone who does MBSs has to write very specifically because there's someone down the line who could be really, really relying on your report. And that's another reason why the MBS IMP is so nice, because it does give sort of everyone similar language to talk about.
Yeah. And I'd imagine it makes sure that everybody hits all of those categories too.
Yeah.
So you're not, omitting some detail about a portion of the swallow or, not covering it thoroughly. Yeah. That seems very, very important.
Very, very important. So in closing, because we only have a couple of minutes left, there's a new pyramid?
There is.
Okay. So for all of us, there's 2 pyramids now?
Yes.
Well, Jiminy Cricket.
There are. One is for solids and one is for liquids. And the official name is International Dysphagia Diet Standardization Initiative, but it frequently goes by its nickname of IDSI. And if you Google it, you'll be able to see what the pyramids look like.
To all of our listeners, we will put links to all of these things on the episode in the show notes. So if you're feeling like you're freaking out because you got to look all this stuff up, just pop into the episode notes and all the links will be there.
So there's thin liquids, and then there's one on the pyramid called slightly thick liquids, but that is really mainly for pediatrics. Pediatrics sometimes will be recommended for sometimes called something a reflux thick. So they'll thicken just a little bit. So try to reduce the reflux. And so reflux thick is now slightly thick liquids, which in my adult world confuses a lot of people. So there's thin liquids and then slightly thick liquids for kids, and then back to mildly thick liquids, which is the liquid formerly known as nectar, moderately thick liquid, the liquid formerly known as honey, and extremely thick liquid, which is the liquid formerly known as pudding. And then on the other triangle pyramid, I guess actually, is puree, which is the same.
Oh, wow.
Yeah.
Puree made out.
That's right. Minced and moist.
Oh God,
Soft
they couldn't
and
come up with a
bite-sized.
different name than minced and moist?
Oh.
Come on, guys.
And then regular.
Wait a minute. So there's puree, minced and moist. What was the other one? I was talking over you because I'm still processing minced and moist.
Sorry. Soft and bite-sized.
Soft and bite-sized. Okay.
And then regular.
Yeah.
And so on the IDSI website, it tells you like how to test all of your liquids and your solids to try to figure out. I mean, because, there's actually a lot of that went into it. But first of all, it's international so that it helps to standardize the language internationally. And then also, like if I work at this hospital and you work at that hospital, we don't necessarily have the same language about even in the same country, even in the same town. And so this helps with that as well. And then also, so like when sometimes like when the patient's recommended for a modified diet and the kitchen makes it a certain way, but by the time it gets up to the patient's room, it's thickened horribly. And so it's no longer the consistency that they were recommended for. And so the IDSI allows anyone, patients, family, staff, SLPs, to test to see what the patient is actually consuming, to see if it's what they should be consuming.
That makes a lot of sense. I mean, this seems like a very important thing that would need to be standardized, especially within a field that has different pronunciations for the same word, right?
True.
And I am not going to get over minced and moist for a long time. Even as you were talking, I was stifling a giggle. I'm a child. But that makes, I think that the standardization, I feel like, is very important. And I'm glad that they did that.
Yeah, it's very costly though to redo whole systems,
Oh yeah,
healthcare
I bet.
systems, and then
Yeah.
get like everyone on the same page. Like the doctors have to order the diets correctly, the SLPs have to recommend the
The
diets, the
vendors have to label
kitchen.
them correctly.
Exactly. Yeah. So there's a lot of like re-education that needs to occur on multiple levels, and you have to get everybody's buy-in as well.
Hopefully, moving forward, though, that will be helpful if you think about a lot of patients who shift from, one level of care to another or one facility to another. It hopefully, especially because they're not necessarily having an updated MBS when they're making that transition, like hopefully that's at least one thing that can remain somewhat consistent.
Yeah.
Yeah, I'm sure it's a lot of work to change.
I am so much smarter now. Thank you so much
Thank
for
you.
all of this information. This was so great. You're such a fun guest. This was awesome.
Thank you for having me. This was fun.
To any of our listeners who have, well, I guess before we transition out, is there anything else that you would like to share or add?
No, thank you.
Okay. So to anyone listening who has questions about anything that was discussed today, there's going to be references and links in the episode notes. We will also maybe try and create a handout to summarize some of this information. If you would like to use this episode for ASHA CEUs, you may do so. You can check out, you can get access to the quiz right in your podcast player, or head over to our website to the episode page and gain access to the quiz. And if you have any questions about anything that we said, feel free to contact us anytime. info@slpnerdcast.com. Lindsay, thank you so much for joining us. This was such a pleasure.
It was
and
fantastic.
so great. And thank you to everyone who has tuned in.